Now for diverticulitis versus diverticulosis. So the pathophysiology is very simple. Diverticulitis begins as diverticulosis, which are little pouches of stress bubbles called diverticula that form on the walls of the lower digestive tract, commonly in the descending colon and sigmoid colon. So just think of the O's in diverticulosis for the O-like pouches, typically caused by a diet that lacks fiber, resulting in constipation and increased pressure within the bowels. This added pressure sort of punches and pushes those little weak spots in the tissue lining, making them bulge out into little pouches. Now, when these little pouches become inflamed, it becomes diverticulitis, an inflammation of the diverticula, or basically those O pouches. So the inflammation of diverticula pouches causes infection and swelling. Now, this all happens because of food trapping due to a low fiber diet that results in constipation. The bowels don't empty effectively and food gets trapped, and this is what becomes inflamed. And specifically, popcorn, seeds, and nuts, studies are showing that this is not a common cause, not as common as they thought before, but exam questions still love to test on this, indicating that it's a major cause of food trapping, resulting in that inflammation. But I would write down for your exams, low fiber and constipation is one of the biggest causes here. Now, in terms of signs and symptoms, write it down here. Fever and chills is a common sign from the infection, as well as nausea and vomiting with, key term, pain in the left lower quadrant. This indicates the descending and sigmoid colon, as well as stopping and starting bowels like diarrhea and constipation, but over and over again. Now, it's key to understand that there's loads and loads of pressure within the intestines here. And if the outpouching sac ruptures, it can cause bleeding. So the key labs to look for is low blood volume. So a decreased H&H, that hemoglobin and hematocrit, if bleeding is involved, as well as increased WBCs from infection. Now, the big deadly complication to look for is peritonitis. Again, just think of the patho. If the pressure gets too great in here, a rupture of those little diverticula can lead to a perforation, or basically an explosion of the bowel, causing peritonitis. So write that down. This is a medical emergency where all the infection or bowel contents leak into the peritoneal cavity. So we must report this to the HCP immediately. So the NCLEX tips to write down is abdominal pain in the left upper quadrant, as well as a rigid board-like abdomen. Again, this indicates that there's internal swelling here and possibly internal bleeding. Again, too much pressure inside the intestines can cause this deadly rupture for acute diverticulitis. So write it down. We don't want to add any barium enemas. This will increase abdominal pressure, and no colonoscopy. We're not sticking any tubes up the butt or through the rectum into the colon area. So write these down. Always question any doctor's order or prescription for these key terms for acute diverticulitis. So just think acute inflammation can lead to a deadly rupture. All right, that wraps it up. Thank you so much for watching. Now for dumping syndrome and GI surgeries. Dumping syndrome is when the stomach empties too quickly into the duodenum, the small intestine, after eating. This dumping causes massive fluid shift, leading to severe pain, low blood pressure, and nausea vomiting around 30 minutes after eating. Now, this complication is seen after any type of bariatric surgery, like a gastric bypass or a gastrectomy, the removal of the stomach, which is typically done for bariatric clients who are morbidly obese. Now, in terms of the causes, the key terms to know for your exam, write this down. Gastrojejunostomy, known as a Bill Roth II surgery, as well as partial gastrectomy or even a sleeve gastrectomy. If you see these key terms, you must think dumping syndrome here. We are in essence removing part of the stomach or most of the stomach and only left with about a thumb-sized pouch for the stomach, a really teeny tiny stomach to help those clients lose weight. So again, look for the gastroectomy here. So gastroectomy and gastrojejunostomy there. Now, in terms of signs and symptoms, we must report to the HCP or the surgeon. These are priority signs and symptoms. So hypotension and tachycardia, as well as sweating, dizziness, severe abdominal pain with nausea and vomiting. And the key number here is 30 minutes after eating. Now, the most critical sign here is the decreased blood pressure. This could be from rapid fluid shifts or even rupture or leakage of a surgical site within the abdomen, resulting in shock, even septic shock or hypovolemic shock, and then death. So the memory trick here, just think dumping syndrome, we see a dumping blood pressure and signs and symptoms of shock. Again, write down these key terms for a gastrectomy and bypass surgery. So a top missed NCLEX question here is a client recovering from a partial gastrectomy, presenting with vomiting, severe abdominal pain, and then here, look for the low blood pressure, 105/62, with a heart rate of 122, that's over 100, and a temperature that looks like a low-grade fever, 100.5. What action should the nurse take? So again, look for the key terms. Partial gastrectomy, so we have to think dumping syndrome. Then look for the dumping blood pressure, 105/62. That's not really extremely low, but it can progress even worse. And then look for the other signs here. High heart rate, low-grade fever. This all looks like septic shock here. So just think, what kills this patient the fastest? For a gastrectomy, you have to think dumping syndrome and even septic shock from a ruptured surgical site. So looking at the options here. Option 1, do we administer a bolus of IV fluid? This one can be a fluid. This one can be technically no. Sure, the client is dumping their blood pressure, but it's not too low. The main reason could be from sepsis, that infection in the blood, showing up as that low-grade temperature. Remember, the question is asking the priority action here that the nurse should take. Now, option number 2, assess blood glucose for hypoglycemia. No. This is pretty close too, because I can see how you're thinking those signs and symptoms kind of look like hypoglycemia, the cool, clammy, and shaky. But again, let the question help you here. The big key term is gastrectomy, so you have to think dumping syndrome first. And the temperature doesn't correlate with hypoglycemia. You have to think sepsis with that high temperature, or basically a bloodborne infection here. Now, option 3, immediately notify the HCP or surgeon. Yes, this is the priority first action. Always report or notify the HCP when you see signs and symptoms of shock. Now, option 4, insert a nasogastric tube. No, this one's close. I can see if you chose that because of the vomiting here. But the question clearly states that the vital signs are indicating septic shock, specifically with the blood pressure and the temperature being elevated there. All right, that wraps. Now for gastritis. Gastritis is the inflammation of the lining of the stomach, occurring either acute, which is short term, or chronic, that long term. So for acute gastritis, the patho is simple here. Inflammation of the gastric mucosa, that stomach lining. So typical causes are alcohol and spicy food, and even aspirins, but NSAID is the top tested. So please write this down. Naproxen, indomethacin, and ibuprofen. NSAIDs destroy the protective layer of prostaglandins that protect the lining of the stomach. Now for key manifestations to also write down. We see hematemesis, or basically vomiting blood, as well as epigastric pain, that heartburn, as well as cramps, among other signs like bloating and even loss of appetite. Now switching gears to chronic gastritis. The patho is a little bit more intense here. We see atrophy of the gastric mucosa as the stomach lining gets destroyed over years and years of chronic inflammation and scarring. The stomach actually changes shape, and much of the normal tissue in the stomach gets replaced with scar tissue, often getting smaller due to atrophy. So for the causes, the big culprit here is the H. pylori infection. This causes chronic irritation and inflammation. Now for complications, we see an increased risk for peptic ulcers and even gastric cancer from all the scarring and tissue damage within the stomach. All right, that wraps it up. GERD and PUD, peptic ulcer disease. Before we get started, let's clarify some terminology. Gastritis refers to stomach irritation, and GERD refers to esophagus irritation, basically heartburn. GERD stands for gastroesophageal reflux, fancy words for heartburn or acid reflux, where stomach acids burn away at the esophagus. And PUD, as mentioned before, is peptic ulcer disease. We have open sores and ulcers inside the lining of the stomach or the intestine. So for gastric ulcer, we have a stomach ulcer. And a duodenal ulcer or a duodenal ulcer, we have small intestine ulcer. So let's break down GERD first. The pathophysiology is pretty simple. We see heartburn from acid reflux. So just let the name help you here. Gastro means stomach, esophageal means esophagus, and reflux is acid, and disease just means disease. Again, this is from stomach acids being kicked up from the stomach into the esophagus, causing pain and injury, leading to inflammation and even cancer from all the erosion. This is what's called Barrett's esophagus, if the chronic acid reflux is not treated. Now, in terms of signs and symptoms, we get a burning epigastric pain known as dyspepsia, or basically heartburn. Now, it's critical to know that this heartburn gets worse while lying down. So write that down. Lying down makes the pain worse. Now, for causes and education, we have a weak or damaged LES, that lower esophageal sphincter, which is the muscle that closes the opening between the stomach and esophagus. So we must avoid anything that can cause irritation or more acid that can further weaken this LES. So the most tested key points that love to come up on Select All That Apply questions. Write this down. Things to avoid when you're eating. So foods that cause acid production. Anything fried. Now trust me, we see this a lot on multiple different question banks. So fries, fried chicken, and even fatty foods. So a low-fat diet is best. And citrus foods can cause acidity, and dairy like milk and cheese can also cause more acid. Now a really interesting one is chocolate as well as peppermint and spearmint. So write these down. These can cause a relaxation inside the esophageal sphincter, leading to worsening heartburn. Now write that down. We saw it on 2 different question banks. And now for the no-no list. No caffeine, including coffee, no cigarettes or tobacco, and no alcohol in excess. Remember, on the NCLEX and exams, caffeine, smoking, and alcohol are never good. Just save it for after the NCLEX here. Okay, now for regurgitation, that can happen when lying down. So we must teach patients to avoid eating before laying down. The big key term here is before. So teach patients the 3-hour window. After eating, they must sit up after meals for at least 3 hours. And we elevate the head of the bed at night and eat small meals. So when you get a client with GERD who states they will have a bedtime snack 1 hour before bed, this is completely wrong here. Major acid reflux is coming. We need to re-educate that client to have the snack and then wait 3 hours before going to bed. So Hesse mentions, which advice would the nurse give to a patient experiencing heartburn after meals? Identify and avoid causative foods. And Saunders mentions, when teaching a client with gastroesophageal reflux disease, GERD, about substances to avoid, which items should the nurse include on the list? Select all that apply. So coffee, obviously. Chocolate and peppermint, those 2 are the tricky ones, right? So hopefully you wrote them down, as well as fried chicken. So again, write down that list. Now, in terms of risk factors, this includes stress and obesity, which is technically a BMI over 30. You see, more pressure on the gastric area can cause dilation of this lower esophageal sphincter, the LES, allowing more acid to come from the stomach and burn the esophagus. So we must teach clients to lose weight. And another cause is a hiatal hernia, which we cover in another video. But it's basically the upper part of the stomach bulges through an opening in the diaphragm, and now acid gets stuck inside this protruding part of the stomach here, causing acid reflux. Now, in terms of pharmacology, the goal here is to reduce acid and prevent this burn. So let's play our next segment from our pharmacology master course. Now, antacids are used for fast, immediate relief. So think anti-mixing for antacids. They're never to be taken with other meds. Probably the biggest test topic I can cover right here. Now, it works by immediately neutralizing stomach acid. But the bad news here is that it doesn't last long. So the acronym we use is SCAM. Like you kind of got scammed from the short duration of the med. So S for sodium bicarbonate, brand name is Alka-Seltzer. C is for calcium carbonate, brand name Tums and Rolaids. A for aluminum hydroxide, and M for magnesium hydroxide. Brand name is Milk of Magnesia. Now that's also a laxative as well as an antacid here. Now guys, the big side effects can vary on the type of antacid. So for aluminum or calcium, they can constrict and cause constipation. And magnesium can mellow out the GI tract, causing diarrhea. Now on the HESI, there was an exam question about magnesium hydroxide. And it said it can upset the stomach and cause liquid bowel movements. So write that one down, guys. Now the key point here and the memory trick, again, really stressing it here, antacids are anti-mixing with other meds. Basically blocks the absorption of a lot of medication. So the key point, never taken with other meds. Always 1 hour before or 1 hour after other meds. And guys, it's not for heart failure patients. Nothing OTC are for heart failure patients or over-the-counter drugs. All these things contain sodium, which swells the body. Now, next up is our long-lasting relief, the H2 blockers, histamine 2 receptor antagonist. Fancy words for turns down the volume of acid production. Now, these end in tidine. So, ranitidine, brand name is Zantac, and famotidine, brand name is Pepcid. Now, the key point is we take 30 minutes before the meals. So think tidine, you take 30 minutes before you go to dine with Tadines. So guys, it's given for GERD and ulcers, both duodenal and gastric. And it works by reducing those gastric secretions by blocking H2 receptors in the stomach. And a big patient education here. We do not overeat, no stress, or basically stress reduction, no smoking, and no NSAIDs, which leads to GI bleeding. Now for the famous PPIs, the proton pump inhibitors, ending in prazole, like omeprazole, brand name Prilosec, or esomeprazole, brand name Nexium, and the famous pantoprazole, brand name Protonix. Now the key points are the 3 P's of prazoles. P for prevents holes. So guys, a key word here is stress ulcer prophylaxis. P for porous bones. So we get regular bone density tests. And P for possible C. diff, or Clostridium difficile infection. So guys, the indication here is for heartburn and GERD, but mainly it's used for ulcer prophylaxis, especially in the hospital due to the hospital-related stress. So guys, nearly everyone in med-surg usually gets put on a PPI. So when a patient asks, why am I on this med since I usually don't take this at home? Guys, the key word here is it helps prevent the development of an ulcer due to the stress of surgery or hospital stays. Now, it works by reducing the gastric acid by inhibiting the proton pump in the parietal cells of the stomach. And once again, for reinforcement here, long-term side effects. P for porous bones. Again, guys, write this down. Regular bone density test. It increases the risk for osteoporosis with long-term use, increasing the risk for fractures on the spine, wrist, and hip. So guys, always take calcium and vitamin D. And lastly, P for possible C. diff infections, since it suppresses the normal HCl in the stomach, which would normally control the intestinal bacteria. And the last key point is we take 30 minutes before meals, which goes for H2 blockers as well as these PPIs. Okay, now for procedures. What if the GERD persists even after diet change and pharmacology? It could mean that the lower esophageal sphincter is not closing all the way, or it might be loose. So we can always send a scope down into the stomach to check this out. This is called an upper gastrointestinal endoscopy. So remember, the word scopy means scope, a small tube with a camera. Now Hesse mentions a patient with persistent gastroesophageal reflux disease despite diet change and proton pump inhibitor. Which test does the nurse anticipate being performed to determine the LES competency? Upper gastrointestinal endoscopy. Now, if ulcers are suspected, then we can go a little bit deeper with an EGD, an esophagogastroduodenoscopy. Woo, that was a big one. So to break down the word real quick, esophagus, gastro means stomach, duodenal, or basically duodenal, is a small intestine, and endoscopy means a scope, a little video camera to check all those areas out. Now, a big complication with any scope inserted into the GI tract is a deadly perforation of the bowels. Fancy words for puncturing a hole, or basically popping a hole inside the bowel here. This can lead to deadly peritonitis and sepsis infection inside the blood, which can kill the patient. So write this down. Peritonitis is priority. We must report these findings to the HCP. So a fever over 100.3, rebound tenderness, as well as a rigid board-like abdomen. Those three love to go up on the NCLEX and nursing exams. But we'll also see increased pain and tenderness, restlessness, and a fast heart rate and respiratory rate. Again, these keywords are priority. But really the most important here is fever. Even the slight increase is bad, because this is an early sign of the deadly sepsis infection post-procedure. Now, don't let the NCLEX trick you here. Blood pressure changes are normal after the procedure due to sedation used during the procedure. And a gag reflex that is slow to return is also normal and to be expected, since a topical analgesic is used to numb the throat to help the tube pass. And speaking of gag reflex returning, we must make sure to keep the client NPO, nothing per oral. So no eating, no drinking until the gag reflex returns. Huge airway risk for aspiration and choking. So Hesse mentions, which action by the unlicensed assistive personnel, the UAP, in the post-procedure, key term, of a patient who is returning from an upper gastrointestinal endoscopy would prompt the nurse to intervene immediately. So you have to think airway. Offering ice chips and water. Yes, the big priority here is NPO, major airway risk. Now, in terms of surgeries, this is our last line therapy if diet and drugs don't work. Not really common on the NCLEX, but it may show up on your nursing exams. Our main goal here is to tighten up that LES, the lower esophageal sphincter, the opening between the stomach and the esophagus here, which stops the acid from backing up. So we can use a Stretta procedure that delivers radio frequency energy through electrodes to tighten up that LES. Or we can do a fundoplication, where we wrap the upper curve of the stomach, called the fundus, around the esophagus and sew it shut. This helps tighten the esophagus sphincter, but again, it's not really tested on the boards. So you don't really have fun with a fundoplication. Now for PUD, the peptic ulcer disease. The pathophysiology is pretty simple. We have open sores or holes inside the esophagus, stomach, or duodenum, also called the duodenum. It happens when the gastric acids erode the gastric lining, creating an open hole, or basically an open sore. So signs and symptoms, write these down. We have dyspepsia, or basically burning pain like epigastric pain that radiates to the back. And in a gastric ulcer inside the stomach, we see pain that increases with food. Write that down. The NCLEX will expect you to know when the pain comes with a gastric ulcer. So it's with food, 30 to 60 minutes after meals. And weight loss is typical because when you eat food with pain, you kind of don't want to eat food anymore. And vomiting blood, that hematemesis, is very common. Now, switching gears to a duodenal ulcer or a duodenal ulcer inside the intestines. Very, very different here because pain is decreased with food. 2 to 3 hours after meals is when the pain comes. And it's worse at night. So we see weight gain as well as blood in stool called melena. So write it down. It looks like dark, tarry stool. So the memory trick we use is for gastric ulcer, we have gut pain with food. And for duodenal ulcers, we don't have pain with food. So just think of the double G's and the double D's. So write that down and know it for your exam. Now, another key point for your pathophysiology class. Stress ulcers occur within hours of a traumatic event, such as, be sure to write this down, burns. A big key term is Curling's ulcer, resulting from a defect in mucosal barrier to secrete acid. Now, other causes is head injury, sepsis, or basically bloodborne infection, and even hemorrhage, fancy words for bleeding. These are related to, at least in part, to low blood flow and perfusion to the GI tract, known as mucosal ischemia, which is aggravated by hypotension, sepsis, and hypoxia, all leading to lower perfusion. All right, that wraps it up. Thank you so much for watching. Don't forget to take your Now, moving on to the practice questions for GERD and ulcers. So, question number 1. The nurse is providing client education on practices to reduce the signs and symptoms of GERD. What does the nurse include in the teaching? So, pause the screen and try your best to answer this question in about 60 seconds or less. All right, let's break this question down following the question breakdown strategy. So first, look at the key terms in the question. The key terms is education to reduce the signs and symptoms of GERD. So think of a few things you know about those key terms. So remember, GERD is that gastric reflux, basically that heartburn. So just think of anything that can cause acid and irritation. So that big no-no list of foods to avoid, and avoid eating right before laying down. And always eat small, frequent meals. That is huge. Now, looking at our options. Option A, it is preferable to consume small meals throughout the day, as opposed to large meals. Yes, remember, small frequent meals are best. So option A would be the most correct. Now, option B is incorrect. Be sure to consume the final meal of the day no later than 9 p.m. at night, or at least 10 minutes from bedtime. No, this is totally incorrect. So the time of the day doesn't really matter. It is more when the client lays down. So laying down 10 minutes before bedtime is a big no-no. The last meal should be about 3 hours before lying down. Now, option C was a tricky one. Peppermint and spearmint hard candies are good for keeping the mouth moist in between meals. No, the big key terms here is peppermint and spearmint. This is on the no-no list of things to avoid. They relax the lower esophageal sphincter and cause more acid reflux from the stomach and into the esophagus. So this will actually make the GERD worse. And lastly, option D, this is totally incorrect. Try lying down after meals as a means to decrease pressure on the lower esophageal sphincter. No, never lie down after meals. We have to wait at least 3 hours before lying down. Now, moving on to question 2. The nurse is caring for a client with a newly diagnosed duodenal ulcer. Should clarify which of the following prescriptions. Pause the screen and try your best to answer this question. So let's break it down following the question breakdown strategy. So always first, look at the key terms in the question. Newly diagnosed duodenal or duodenal ulcer. Clarify which prescription. So think of a few things you know about those key terms. Duodenal ulcers are basically ulcers or those open sores in the duodenum or duodenum. Which prescription or order would cause the most damage here? So option A, ranitidine. No, this is actually an H2 blocker that reduces acid. Remember, take tadines before you go to dine. And option B was a little bit tricky here. Tetracycline. This is incorrect because this antibiotic has actually been shown effective to kill the causative bacteria H. pylori. Now, option C, ibuprofen, the NSAID. Yes, this is the most correct. We want to avoid this. Remember, NSAIDs are not good for clients on exams, since NSAIDs reduce the protective prostaglandins that are supposed to shield the intestinal lining. So without that protective prostaglandins, ulcers and scarring can develop. And lastly, pantoprazole. This is incorrect because we actually give pantoprazole. It's a PPI inhibitor to reduce acid and actually helps treat ulcers. So option C would be the most correct here. All right, that wraps it up. Thank you so much for watching. Now for GI bleeds. As you know, the GI tract is like a plumbing system, starting at the mouth, down through the esophagus, to the stomach, to the small intestine, and then through the colon, our large intestine, and then out the rectum through the anus, from the body and into the potty. Bleeding can occur anywhere in this GI tract, and it usually is classified as an upper or lower GI bleed. Now, one of the biggest problems with the GI bleed is knowing the exact location of the bleed. So for causes and risk factors of an upper GI bleed is gastritis, GERD, and even a peptic ulcer. Big NCLEX tips right there. Now, these are the most common, but we also have esophageal varices, which is the most deadly, from a complication of cirrhosis, or liver scarosis as we like to call it, which we cover in the liver lectures. And we also have lower GI bleeds, typically due to hemorrhoids, colorectal cancer, another big NCLEX tip, as well as diverticulosis and ulcerative colitis, where we get big ulcers inside the colon there. Now, how do you know if it's from the upper or lower GI? Well, signs and symptoms for an upper GI bleed, big NCLEX tip again, is vomiting blood, known as hematemesis. We see this as coffee ground emesis, as the blood is partially digested inside the stomach. And in the stool, it's called melena, or basically dark or black tarry stool, as blood is digested in the higher GI tract. Now, a lower GI bleed will typically present with bright red blood, since this bleed is coming from the colon or rectum area, and it doesn't have enough time to be digested inside the GI tract. Now, in terms of diagnostics, we use a Guaiac-Finkel occult blood test. So write this down. The NCLEX expects you to know the correct sequence of how to use this Guaiac-Finkel occult. So number 1 is gather supplies, wash the hands, and use non-sterile gloves. Number 2, you open and apply the stool samples to a box on the slides. Number 3, you open the back of the slide and apply 2 drops of developing solution. And number 4, you wait 30 to 60 seconds. And lastly, number 5, document the results. A positive Guaiac test will return with blue paper here, indicating a positive for blood in the stool. Kind of like a pregnancy test where we get positive blue sign, just think a positive blue means that there's blood in the stool. Now for complications, in severe cases with massive bleeding, clients can lose too much blood and go into hypovolemic shock from too much bleeding, called hemorrhagic shock. So shock, just think severely low blood pressure as the blood fills up the bowels, and the body will begin to shut down due to the lack of oxygen to the organs, that lack of organ perfusion. So the key signs to know for the NCLEX, for really any type of shock, is hypotension here, low BP, tachycardia, that high heart rate, as well as pale skin, known as cool or clammy, and even diaphoretic, that sweaty skin. We'll also see our clients have fatigue and dizziness due to that lack of oxygen there. Now, for low CBC labs, we'll see a low H&H, basically a low hemoglobin and hematocrit, but really the key number to know on the NCLEX, write this down, is hemoglobin less than 7 sends your patient to heaven. Now, a big key number right there. So again, write it down. Hemoglobin less than 7 sends your patient to heaven. Big medical emergency. Clients will die if they have a hemoglobin less than 7. All right, that wraps it up. Thank you. Now for a hiatal hernia. A hiatal hernia is essentially a protrusion or displacement of part of the stomach through the diaphragm, and now it gets stuck in the thoracic cavity, either in the esophagus or to the side of the esophagus. Initially, the stomach may slide in and out of the esophagus, but with time, it becomes fixed in the chest area. So, key signs and symptoms to look for. Usually, clients present asymptomatic or without symptoms, but as the condition gets worse, it can obstruct the esophagus, leading to, key term, dysphagia, that difficulty swallowing, as well as gastric reflux. And key signs include heartburn, known as epigastric pain, as well as chest pain and shortness of breath as the condition gets worse. Now, in terms of causes and risk factors, just think anything that can increase abdominal pressure, like straining, lifting heavy objects, or even weightlifting exercises, can cause this increased pressure inside that abdominal cavity, pushing the esophagus up into the diaphragm area. As well as obesity, having a large abdomen adds large pressure. So with clients trying to lose weight with a hiatal hernia, always avoid lifting weights or weightlifting exercises. So no heavy lifting. Do something like cardio, like walking or maybe even swimming. All right, that wraps it up. Thank you so much. Irritable bowel syndrome is an intestinal disorder that affects the large intestines, causing cramping, abdominal pain, bloating, gas, and even diarrhea or constipation. Now, IBS is not IBD, that inflammatory bowel disease, which is the inflammation of the bowels, as the body's own immune system is attacking itself. Common diseases include UC, or ulcerative colitis, as well as Crohn's disease, which we cover in detail in another video. Now, the key point is patient education for both IBS and IBD here. So write this down. We need to keep a journal of the symptoms, as well as the diet, and key term here, stress levels. And number 2, perform exercise 3 times per week. Now, the big difference here is the diet. So diet for IBS, we want to increase fiber and fluid intake. So Kaplan mentions, the priority instructions for a client with IBS is to increase fiber intake to at least 30 grams per day. Next, we want to limit or reduce intake of gas-forming foods. Number 1 that's tested is legumes, or basically beans, but also eggs, dairy products like yogurt was another commonly tested one, as well as fruits. And lastly, we want to limit or reduce alcohol or caffeine intake. Both of these guys cause an increase in gastric motility. Now, a top missed NCLEX question here. A client with irritable bowel syndrome, which meal choices demonstrates correct understanding of diet guidelines? Select all that apply. So option number 1, beans. No, we have to avoid the beans. Option 2 is correct. Yes, cornbread is okay. The key term in here is bread. Now option 3 is fruit salad. No, we always want to avoid those fruits. And option 4 and 5 are correct. Steak is a good protein choice here, and tomato basil soup. Remember, soup always soothes the bowels here. And lastly, option number 6, yogurt with granola. No, remember, no dairy. So the key term here is yogurt. So avoid the dairy here. All right, that wraps it up. Thank you so much for watching. A small bowel obstruction is the blockage in the small intestines, caused by both non-mechanical obstructions as well as mechanical, with mechanical meaning that there's something physically blocking the GI tract. So for causes and risk, non-mechanical obstruction is from a paralytic ileus, fancy words for a paralyzed bowel. Everything stops and the bowel can die, typically after GI surgery or even opioid use, which makes everything low and slow, especially inside the bowels. And mechanical obstruction which is that physical blockage, from adhesions like scar tissue from surgery, even from hernias, and intusception, where a part of the bowel gets stuck into another, kind of like a telescope, and also from tumors, from cancer, and volvus, basically just a twisting of the bowel. Now, when a bowel obstruction occurs, it develops with both gas and fluid collecting above the site of obstruction, causing a lot of pressure. Kind of like a fat kid getting stuck in a water slide. Like that chubby kid in the movie Willy Wonka and the Chocolate Factory who gets stuck in that chocolate tube. This is not good. So naturally, we hear hyper bowel activity above the site of obstruction and hypo bowel activity below the site of obstruction. So signs and symptoms of a small bowel obstruction develop faster than a large bowel obstruction. This is because small bowels are smaller, allowing for more rapid obstruction. So the key point for a small bowel obstruction is rapid onset. So write this down. Frequent vomiting and nausea, as well as abdominal distension, described as colicky, or basically intermittent abdominal pain. Remember, it's a rapid onset, happening quickly. And again, bowel sounds. We hear hyperactivity above the obstruction and hypoactivity below the obstruction. Now, don't let the NCLEX trick you here. Not constipation or lack of flatus, or basically passing gas, which are typically late signs and more common with large bowel obstructions, which develop slower. And not painful pooing or defecating. This is common for rectal problems like hemorrhoids. As for complications, just think of the patho here, like a fat kid getting stuck in the water slide. We have a lot of pressure building up behind this small bowel obstruction. It's kind of like a ticking time bomb. The bowels can explode all over, leading to a perforated bowel, which eventually leaks into the peritoneal cavity, causing peritonitis. Again, this is a medical emergency, very deadly. We cover it in all the lectures pretty much in this GI series. So the NCLEX tips, once again, look for fever, tachycardia and tachypnea, as well as abdominal distension. And a key term here is a rigid board-like abdomen. The client needs immediate surgery or they will die from septic shock, that infection all over the body. So a common exam question. A client with a small bowel obstruction suddenly develops tachycardia, tachypnea, and high fever. What is most likely the problem? So option 2 here, a bowel perforation. You must notify the HCP because this client needs immediate surgery or they will die. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz.